Welcome to AETCM, the emergency medicine channel. We received a 29-year-old male at late night to the ER with complaints of the pain per rectum.
Okay.
On initial triage, the patient was having respiratory of 18 per minute, saturation of 99%, BP of 120 by 80 and heart rate of 72. So he was taken into green area and we started with the sample history. The patient has given the history in such a way that he had a foreign object placed in per rectum. The mode was he was trying to pleasure himself, and a piece of cucumber wrapped in a condom has been inserted per annum. So we have a 29-year-old with such.
So that is a history. So basically, a 29-year-old male has come to the ER with the pain in the anus, and he had an history of inserting a cucumber inside his hand. Okay, fine.
Right now, history taking patient has no any bleed or any discharge from per rectum after insertion. Patient had not removed the object after insertion, nor the object has been coming out on forceful exertion when he was trying to pass stools. And the shape of the object is a blunt object, not any sharp object.
Okay. So, see, what are the concerns that we have right now? So, you have to consider here the most important will be the pain. And another will be a lot of psychological aspect that is getting involved into this. So, that is what we have to take care as an emergency physician when we discuss such cases. When we have definitely after some time we will be discussing in a different way rather than what we are discussing right now. So that should not happen in front of the patient. So definitely a psychosocial support to the patient is definitely needed. You need to consider whatever be the reason, whether it's for the pleasure or maybe somebody have tried or they have trying to experiment or something. All those things, it is a painful thing for the patient. So that is the most concerning part here, and we should handle it very in a professional manner. So that is the most important part. And now the issues that what we are going to see is that the foreign body is still inside. And as you suggested, it is a blunt object. So it directly penetrating injury chances are less. So it is very short span the object has been inserted. And the chance of a peritonitis straight away is very less. Only first concern to relieve his pain. So that will be our idea number one. And we need to see whether it has caused any complications. If at all complication, how will you tackle that complication, and how will you remove the foreign body? And before removing the foreign body, we have to confirm where exactly the foreign body is located, whether it is in the rectum or it has dislodged into the sigmoid also we need to do. So our plan of action in the ER will be on these aspects. The first aspect I will say will be the psychosocial support to the patient. So that should be the first thing that should be done. It is an embarrassing moment for the patient. So we should not be asking again and again multiple questions again and again why you have done this. All those questions should be avoided because that is not our concern right now. Later definitely he needs some psychiatry support or whatever be it is. But our aim is to how we have to remove this. How prevent the complication. If at all any complication has occurred, how will you tackle that complications? So that are our concerns. So can you just elaborate on these aspects on how we managed on
initially on insertion of foreign body per rectum, we divide the objects as blunt or sharp. Or in the recent scenarios, body packers are also being seen.
Body packers has been seen since long time. Maybe recently because of the media and all, we are coming to know a lot about body packers. So it has been there. The first incident 1990s, early 1919, it has been there. So the body packer syndrome stays for a long time. So body packers is a totally different perspective because the body packer syndrome, the product whatever they are carrying can burst inside the absorption, and as a result there can be an absorption, and totally the toxicity clinical scenario will be totally different. And here it is not a body packer, but maybe we don't know if he had done something, but we are not very sure.
So initially on arrival, on examination, we need to rule out the major complication of this is the perforation causing peritonitis. If there is any hypotension, if the abdomen is rigid, this kind of signs and symptoms we need to elicit and we need to rule out that. Apart from that, radiological examination would be helpful if it is a metallic object, so that which we can see it in the radiograph extent and the other parameters. And the basic in examination,
depending upon the object, X-ray is going to help a plus or minus. If the object is not going to be appearing in your X-ray, then there is no point in doing that.
And the initial examination PR is the most helpful. In the PR, we would like to see if there is any lacerations, tears, or if we are finding any blood stain marks which proves that there has been mucosal rupture,
Yes.
which would be the complication, initial complication which we have to tackle. So in this patient, a PR has been done, but the anal muscles were tight, and we could not palpate the full cucumber. We could only feel the tip of it.
Okay.
So we could not extract it through the PR.
Okay.
Next,
So how safe it is to extract it blindly with the help of a PR?
for the blunt objects, transanal approach is allowed. But it's just that we should not give a laxative, and we should do the...
Because it's very clear what object he has put inside your anus, so that's the reason why we can ask it for. But otherwise, if you doesn't know the object, maybe it is a part of rape or something. It can happen. It's a part of a rape, or somebody had inserted a penetrating object. It is very unsafe maybe to remove the object without doing a radiological evaluation properly. Maybe with the help of endoscope only, or a sigmoidoscope or a proctoscope only, we'll be able to do that.
So in this transanal approach of removing the object, we can have additional benefits by giving intravenous sedation or pudendal nerve block, so that the musculature there can be relaxed, and we can get a proper anal tone, release the anal tone, and we can
remove the object. Okay.
The idea would be then to introduce proctoscope. If PR is not useful, proctoscope to visualize the object. Usually under visualization only, better to remove the object, so that we will know whether if there is any perforation.
Perforation is there or not. Fine.
Then in this case scenario, we tried with a proctoscope. We could visualize the cucumber tips, and we tried to introduce a sponge holding forceps to grasp the cucumber and pull it, but it wasn't coming out. Next, for the blunt objects, the other techniques which we can use is placing a Foley's catheter above the...
Placing it above and filling it with the saline, inflating the balloon and pulling it down.
Otherwise, injecting air in between the cucumber and the above vacuum, so that this air can
push.
Otherwise, if it's a metallic object, we could have used magnets. It's such kind of practical options we can use only if it is a
blunt object.
If it would have been a sharp object, definitely an X-ray or CT has to be done.
Taken.
Apart
it should not be done blindly.
Should not be.
The removal should not be done blindly. That's a main concern here. Then.
And a colonoscopy, any visual guided approach should be done. And these are just the objects which haven't shown any signs of perforation. Suppose if you have a case of perforation causing the foreign object causing perforation, then as a case of normal intestinal perforation, which should be treated
straight away to the laparatomy. Should be taken to the theatre.
And even NPO, dehydration,
all those things, infection, all those things that you should take care of then.
Regarding endoscopy approach, we can endoscopy snares will be the tools through which we can pull
down. Okay.
And regarding there is a classification by American Society of Surgery dividing rectal injury into 5 categories
depending upon the severity.
First category is a contusion or hematoma or partial thickness in the wall of the rectum. Second category is across the circumference less than 50% laceration. Grade 3 is greater than 50% laceration. Grade 4 is laceration complete with extension to perineal body. And grade 5 is part of the rectum is removed, devascularization of the rectum.
Here what you can put as a grade?
Grade 1.
Grade 1. Just a minor hematoma only at the site of the injury is there. Okay.
And actually in our case, the patient had an urge to defecate, and he had defecated, and the object had come as a whole. It did not
broke or partially didn't stay inside. So it came out completely. So that's one thing. Then further any evaluation has been done for him?
Actually, in such case scenarios, post-removal management is required. In such cases, we require to put a scope and go through and see if it doesn't cause any mucosal damage injuries or perforation, so that we can be sure that the patient will not develop further complications. Once that is done, we could have discharged the patient. As this patient had passed a complete full object, is it same, and he has the confidence that nothing else has been placed, we did not further go with the scopy.
Definitely he needs an counseling
and psychological support was advised.
And also if the high risk behavior is there with him, and definitely he should receive STD, sexually transmitted diseases counseling, as well as maybe a background serology we should always do, and maybe a prophylaxis. If it is a part of rape or something, we should always consider probably a pregnancy, unwanted pregnancy, so it's a female patient, that part also we should take in care of. So sexually transmitted diseases, for prevention of sexually transmitted diseases, how will you prevent that? And as well as an unwanted pregnancy, if it's a part of a rape, I'm telling you, if it's a part of a rape, all the emergency pill or levonorgestrel, whatever be the doses, we should recommend that also. That we should keep in mind. Don't think that it's a male patient, it can be a sexual abuse also. We don't know whether it's a part of a sexual abuse. So an STD screening and a proper prophylaxis for that, depending upon the type, maybe a doxycycline or crystalline penicillin, whatever be it is, he requires that prophylaxis. So that part you should take in care of. So that part sometimes we will miss it. Once the foreign body is out, we are okay, fine. But background history after the incident, we can definitely that's the importance of counseling comes in. We had a patient who has been abused for a long time, pretty long time, and he had developed sexually transmitted disease, and he didn't tell anyone, and later his stage we couldn't do anything to that patient. So that is a point where the counseling and all that help. We don't know whether it was with the will it has been done. The patient will be giving this history, maybe in front of a counselor the history will be totally different. So that part is very, very important. That part you need to take in care of. Fine.
Sir, we can actually divide the placement of the objects in anus as voluntary, involuntary. Involuntary being rape or assault, and sexual or non-sexual. Involuntary, non-sexual foreign objects mostly seen in children or mentally ill patients who would have placed some object without knowledge placing in that. And voluntary, non-sexual placement would be the case of body packing, or if they were illicit drug users. And more common is the sexual way of the patients, and mostly it is in men in the years which we'll encounter.
That part we have to take care of. Anything else?
Nothing.
Okay. So the take home message will be the object, whatever be the foreign object in the anus or the rectum, whatever they have inserted, the management depends upon whether it's a blunt object, type of object first, then whether it has caused any complication, and whether the complication, how to tackle the complication and how to remove it. Whether we can just by visualization we can remove, or with the help of some aid we need to remove, or if there is evidence of perforation, straight away that patient go for surgery. And most importantly, don't forget regarding the counseling, the psychosocial support that these sort of patient requires in later. Fine. Thank you.